Hey everybody, so I'm Lauren Hudak. I'm one of the presenters today, and I was just going to go through a little bit about our speakers today and our interest in firearm injury prevention, and also talk about our strategy on addressing it, so the public health approach to firearm injury prevention and next steps for research. So just to go a little bit over who we are, so Megan is on her way, so should be coming in here. So she's an associate professor of emergency medicine at Brown. She completed an injury prevention research fellowship and focuses mostly on the intersection of digital health and injury prevention. And she's also recognized as a national leader in firearm injury prevention research. So she serves as the ASEP Firearm Injury Prevention Technical Advisory Group Chair for the Firearm Group. And she also is the Chief Research Officer for the Affirm group, that is a grant group I'll talk to you guys about as a source of funding for firearm injury prevention research. She's the co-PI or PI on a bunch of projects within big funded programs. So she's very well equipped to talk about that. So she'll be our first speaker. To tell you a little bit about me, I'm an assistant professor of emergency medicine at Emory. I am one of the co-chairs for the Violence Prevention Task Force of our injury center. And injury prevention in terms of firearm data collection is my main interest in surveillance data and how to kind of get local community risk factors and connect that with policing data. So I have kind of a data interest. And also I'm a new person, so I'm interested very much in funding. So I'll talk to you guys briefly about that. Oh, there's Megan, I'm just going to keep going. And then Patrick Carter is over here on the end. So he is an assistant professor of emergency medicine at Michigan. He's part of their core leadership team, is also the assistant director of it's a funded injury center, so they're doing really great up there at Michigan in terms of injury prevention work. His research interest is to better explore firearm violence among urban youth and minority populations, as well as some intervention work in that area as well. And he's funded on a vast number of grants there as well, so very well equipped to talk about this problem. And then lastly, last but not least, is Dr. Jeremy Ackerman. So he's associate professor of emergency medicine at Emory. And he has a lot of experience in a vast number of things, including devices, and there's nothing that Ackerman doesn't do, but he's very interested in developing strategies on training residents to be more proficient in firearm discussions with patients, and also how we can be comfortable with mechanics of firearms ourselves, because us ivory tower people sometimes may not have that experience with firearms and know how to knowledgeably discuss things with patients. So with that, I know I feel bad that Megan, you are up first.
No, it's all good.
Really like walking the room.
It was a great intro. So, thank you.
Yeah, no problem. And then, so first, just to give you an outline of what we're going to talk about today. So first, we're going to talk about the public health approach to firearm violence and how we think about it from a public health perspective. So Megan's going to kind of lead off with that. I'm going to talk a little bit about funding disparities, both in public as well as some of maybe foundation grants we can look at for opportunities for research, and also what data sources we can use to drive our denominators for research and how to measure our program effectiveness. And then Patrick's going to talk a good bit about some of the intervention work that we can do, how we measure some things, and how we look at different risk populations in suicide and youth violence. And then we're going to kick it off the end with Ackerman talking about how to talk to patients and how we can be more knowledgeable as providers in this area. So with that, I will turn it over to Megan.
Awesome.
Thanks, Megan.
Thank
Sorry.
you, Lauren.
Yeah. I don't know if it's easier to just turn.
Yeah. It's a little bit of, I'm used to let me stand. I don't like sitting and talking. Oh, that's awesome. That's fine too. Yeah.
Same opposite.
Thank you. Oh, really? All right, so I'm going to start us off by talking a little bit about the epidemiology of firearm injury to set the stage for the rest of the talks. I'm going to give an acknowledgement to Dr. Emmy Betts from Colorado and Dr. Garen Wintemute from UC Davis, who are two long-term collaborators with whom I have given portions of this talk many times. So the underlying thesis behind what all four of us are going to be talking about is the answer to this question: should doctors talk about guns? And you're here, so I'm going to guess you agree with me, which is that the answer is yes. But as you know, in the larger American community, there's sometimes some debate. And so I see that part of my role is to help educate and convince people to understand why and how it's an important discussion for us to have. The reasons why, as doctors, regardless of our political persuasion or where we practice, it's important for us to talk about guns is a few things. We are already involved, right? Certainly as emergency physicians, we're involved in patient care. We are the ones who take care of the GSWs. We're the ones who tell the grieving family members that their loved one has been lost. We're certainly involved in terms of hospital and clinic safety. I don't know about you, but we had yet another active shooter drill at my hospital a couple of weeks ago. And as emergency physicians, we're generally part of the mass shooting or disaster planning for our communities. And we're, of course, also involved in terms of legal questions. Each state is a little bit different, but in my state, I have to report all GSWs to the police, right? And for some of you, you may be mandated reporters for domestic violence, for stabbings, for other entities. So there are legal questions that we are already involved in. We are also very much a part of the solution. Just as we don't just take care of patients with chest pain without talking to them about smoking cessation, right? Similarly, we should not and must not just take care of patients who are victims of gunshot wounds or who are at risk for gunshot wounds without also talking to them and to our larger community about ways to keep them safe. Most of all, we can do this using evidence-based methods, right, that are acceptable to patients and providers. And that's where Pat is going to talk a little bit more about some of the evidence that's out there right now. But I will say, and Lauren will talk about why we don't have more evidence. So let me start with the epi. So I think it's important as we discuss firearm injury for us all to be on the same page about what's happening and why it's important. So to orient you, up and down are the number of deaths in the thousands, and across the bottom are age groups. So who dies from firearms in the United States? So this is our graph. Male and female, 85% of firearm deaths in this country are boys and men. When you look by, again, numbers going up and down and age groups going across, when you look by race and ethnicity, so this is a number that surprises a lot of people, right? So there's a huge spike in non-Hispanic white and Hispanic youth in the younger age groups. But in the older age groups, it's mostly white men. And so 62% of gun deaths nationally are non-Hispanic whites. The 28% who are non-Hispanic blacks, and then the smaller around 10% that are Hispanics, those are generally community violence, right? And then what do you guys think is the cause of the non-Hispanic white deaths? Yeah, suicide, right? And I think that this is a really important distinction to make, because when you look at the distribution of deaths, over 38,000 Americans died last year of a gunshot wound. Less than 2% were accidental, right? Less than 1% were mass shootings, despite the fact that that's what dominates the news. Approximately 40% were homicide and legal intervention. But 60% were suicide, and that was actually a lower percentage than the prior year, where it was closer to 2/3. It's important for us to talk about this distribution because our means of preventing and dealing with each of these different type of gunshot wounds and deaths is likely going to be different because the precipitating causes are also different. I also think it's important to acknowledge that deaths are only the tip of the iceberg. Now, firearms are a little bit different from every other type of injury. Usually we talk about there being an injury pyramid, right, where there are thousands of injuries, most of which don't come to the ED. There are hundreds that come to the ED, dozens that get hospitalized, and then just a few that die. Guns are different, right? It's a much more up and down. For every 2 people that are injured, 1 dies, and almost all of them come to the hospital. But nonetheless, the cumulative burden of gun injuries is much greater than the burden of gun deaths. And this is a graph that I actually got from a friend on Twitter, where he graphed out after Parkland injuries and deaths among kids in the first 50 days of 2018. And the greens are the school shootings, of which Parkland was, of course, the most horrific and the one that captured the national imagination and spurred a lot of change. But there are other school shootings that were less talked about, right? Largely because they were happening in urban areas. They weren't, no offense, like they weren't well-off white kids, right? And so nobody talked about them. And there were a lot of injuries that weren't talked about. Another important statistic to acknowledge isn't just the patterns of injury and death, but also the distribution of firearm ownership and gun deaths. This is a map that shows firearm ownership by state from 2013. I'll note the data is really difficult to come by, but the lighter the color, the lower the rate of gun ownership. I'm from here in Rhode Island, where we are far less than 20%, but my collaborators, Emmy, is in a state where Emmy Betts is in a state where more than 40% of people are gun owners. Pat lives in a state where it's somewhere around 25%, right? And down in Atlanta, yeah, you're somewhere around 30 to 40%. And of course, these stats are not super reliable. The patterns of gun death also differ from place to place. Alaska has perhaps the highest rate of gun death in the nation, and that is almost all suicide, right? Whereas for many urban areas, again, it's mostly homicide, and you'll see little blips around, for instance, Detroit or Chicago. And gun ownership gun ownership rates don't always directly correlate with death rates, which is an interesting question from an injury prevention perspective. And I'm going to make one note about guns and suicide. A lot of times when I give these talks to physician audiences, people say, well, that's great, but suicide isn't really that's not really gun violence. When you're talking about gun violence, you're talking about homicide, and homicide is criminal, and suicide, well, that's not preventable. So I don't want to talk about it. So I think it's really important to just kind of say out loud that only 10% of people with suicidal thoughts or actions die. But people who try to commit suicide with a gun, 90% of them are going to die. And importantly, that final decision to act is often impulsive, and if we can keep them from having access to lethal means in that moment of despair, we can often prevent the death, right? So the framework for action, very quickly. So public health, what is it, right? Many of you in this room already believe in the public health model, but there's a few basic concepts, very few of which we are unfortunately able to realize around guns right now. But first step is surveillance, which I kind of just did. What's the scope of the problem? Next, what are the risk and protective factors? What are the causes? Why are people getting hurt? What is it that could be potentially modifiable? Then you develop interventions. And the types of interventions, there are a few. So we talk about education. So using like the drunk driving example, education is telling people don't drink and drive. Enforcement and enactment would be saying it's illegal to drink and drive. Engineering would be things like putting a breathalyzer in the car so that people can't drink and drive, right? And we can do similar types of interventions, most likely, for all types of firearm violence. Once we create those interventions, then we have to implement them and study whether or not they work. This framework works, and the other three are going to talk about ways in which we can and have implemented it, but I'm going to talk about places where we have made it work nationally, not for guns, but for car crashes. We have more cars on the road than ever before. We have the number of miles driven is greater than ever before, and yet the deaths per 100,000 is decreasing. HIV/AIDS. There were no HIV/AIDS deaths, right, because it didn't exist. Then it peaked. Little blip in the 80s, peaked in the 90s, and then it decreased. It decreased for a variety of reasons. One is we did research and we developed medications that make HIV a chronic disease rather than an immediately fatal disease. The other reason is that we did those other types of interventions, right? We did education campaigns. We talk about safe sex. We as physicians have been trained in medical school and beyond how to have non-judgmental harm reduction conversations with our patients, particularly our at-risk populations. But guns, same. We had a little blip that then went back down in the 80s and 90s that we think is largely due to crime around the crack epidemic. But other than that, our rate per 100,000 of deaths is virtually the same, or a little bit higher than it was in 1950, right around 10 to 11 per 100,000. And I will note there that our rate of death from guns is actually approximately equal to the rate of death from prescription opioids. Gail D'Onofrio gave a great keynote where she talked about 115 Americans die a day from opioid overdose. About 100 die per day of guns. So with that, I'm going to turn it over to Lauren to talk a little bit about why we don't have all the answers yet.
I think I'm going to sit. It's probably easier. Okay, let's see. All right. So, I was going to talk to you all a little bit about some of the funding disparities and the data sources you can use when you decide to start moving more towards doing research or being active in this area. So we can't really get out of a discussion without talking about the Dickey Amendment. So I know in 1996 there was a congressional appropriations bill that stipulated, it was kind of a rider on that appropriations bill, which dictated, quote, none of the funds may be available for injury prevention and control at the CDC may be used to advocate for or promote gun control. So it didn't outright sort of ban research and firearm violence and injury, but it did put kind of a heavy onus on the topic, and it actually kind of extended into NIH, but there was never really an outright ban, so that's one thing to sort of clarify. But recently, in March of this year, there was language that clarified that, so that the CDC actually can conduct, and they did
make sure that we can clarify that that's real and we can start doing research in gun violence. So the CDC hasn't quite translated that yet into funding opportunities, but that's still something we can think about, and that's hopeful. So there's some hope in the horizon. So with that in mind, let's move to the disparities in firearm-related public funding opportunities. So you can see the different disease processes here. So, cancer and heart disease, and you see firearm-related deaths here, and especially related to potential life lost. So you can see that a big killer here is firearms, right? When you look at the columns that are made available for public funding, however, in their respective topics right here, you can see there's just a tiny little hair, like really not much in terms of public funding opportunities for firearm-related research. If you want to look at it another angle, so relatively rare conditions like cholera, diphtheria, polio, rabies, in the last 40-year period, there's very few cases. You can see just, 2,000 or so, but the NIH research awards dedicated to that were about, 500. So over the same 40-year period, the amount of death, not death, this is death and injury, over 40 million total cases, but only 3 research awards. So it's a little bit, I don't want to squash all your hopes, but so continuing on, if you look at this from a different angle, does this translate into publications? So if there's not any funding, can we see that publications are actual research and science? Is this translated in that as well? There's a recent JAMA paper that came out this year that actually does show just that. So figuring out how the funding and publication volumes relate to mortality, they used 2 linear regression analyses. The first was the mortality rate as a predictor for funding as an outcome, and the second one was a predictor of publications. And so you can see here gun control and sepsis are kind of right along the same in terms of how many folks die as a rate, but you can see the amount of funding that's available is not very much. And also you can see here as translating into publications, yes, it's also very limited. There's not a lot of work and a lot of science being put out about firearm injury prevention. So with that, so don't lose hope is what I want to say. We're going to go into a little bit about how therefore what we can say is underfunded and it's understudied. So relative to those other big killers in society, we really need to reframe how we think about firearm injury prevention and funding as well. So if you are going to try to get out there and get some funding, I wanted to talk about some of the opportunities that are out there just so people can sort of think about ways to get started in the area. So the NIH, as we mentioned, they're limited in number, but if you do tie to other specific areas like mental health, so if you're suicide prevention, there's a lot of opportunity there, alcohol, and also child and unintentional firearm injuries. Those are ways you can tie in to other projects and get NIH funding or proceed with that. The DOJ and the NIJ, actually, I just finished applying for one on Monday, but there was one on, I know, right? So that they have opportunities with them, but they tend to be more criminal justice focused, so you tend to have to tie with policing initiatives, violence prevention specifically, and a lot with criminal justice policy. They really want to know about policing patterns and how the work you're going to be doing is contributing to their work. Also, on the non-public side, you've got foundational grants, and so I should have introduced more about what Megan does with a firm. So that is, I'll have to look at the exact acronym, but it's a specific area that's studying firearm injury prevention within medicine, and so she chairs one of the advisory committees on that, and they do fund projects related to firearm injury prevention research and medicine, so how we do it as providers, if I'm saying. Yes, and then there's Fund for a Safer Future. They have a lot of nonpartisan options that you can look into, and they do consistently fund, especially related to suicide prevention. Joyce Foundation is very heavy sort of Great Lakes region, but they do have a lot of opportunity as well for firearm injury prevention. The rest of them are kind of, there's a lot out there. They're not always consistent and not always as big money as what you'd see in your public grants. And then they sometimes have partisan themes to them that may or may not be, in line with what people want to do. So also, if you're new like me, institutional grants are fabulous. So you can look at your own institution, look at like little pilot grants, start getting your foot in the door with those sorts of projects and data-related projects, and you can maybe transition into bigger funding after that. So those are other options. And then I put CDC there because I'm like, I think maybe after this last March, there might be something that becomes opportunities. Within their injury center, they do fund violence-related projects, but nothing that's specifically firearm-related. All right. And so in terms of firearm data sources, so say now you want to go ahead and get started on your work. There's a couple of as Megan had mentioned, the epidemiology is there. It's just difficult to get centralized data that lets you apply that data to your local programming. So you'll see there's really great data sources such as the National Violent Death Reporting System. As you guys know, that the death, it's just death data that those record, and it's robust. It has location, types of firearm used, and really, really great narratives that help you kind of tease through what specific variables you want to look at. It's collected in 40 states, and they just approved to collect in all 50, even though that hasn't quite happened yet. But if you're a state that participates, there's some really great data in there. The National Electronic Injury Surveillance System is kind of an interesting data system that's newly being explored. Some of the larger groups have used it for national data. They think of firearms as a consumer product, and it is technically. And so looking at it from that lens, you can look at the injuries caused just like blenders and other things. You know, this is the injuries we see, the body parts, the diagnoses that are coded, and also some other kind of unusual risk variables such as blunt injuries from firearms you can tease out through their data, as well as injuries fleeing from firearms, and sexually assault facilitated firearm injuries as well. So they have some kind of interesting risk variables that you can explore. The unfortunate thing about it is it's in a restricted data set from 2013 onwards, so that we don't have as recent data, but we're looking to explore in that, and there's a lot of us that are working on that currently now. There's other kind of survey-based data, so things like NHAMES and the NEDS. All of those tend to be big surveillance data systems that don't really code anything specific other than just firearm injury. So it's not as, you can get sheer counts, but not really that granular data that you need. So that's why maybe going to your own hospital data, kind of looking at that, and pulling what specific violence trends you're seeing in your own community would be a helpful thing to start. Criminal justice data is also very promising. You can link between the victim-perpetrator sort of situation that's very hot right now for funding. So if you want to look at specific variables about your victims also being perpetrators, so we have there's a couple of folks doing work on that. Linking, local linking, including models like the Cardiff model, where they look at all coming violence in the hospital and then map it, like geospatial hotspots for mapping of violence, and then comparing that to the criminal justice data to see what sort of areas are underreported. Like Megan said, sometimes she's required to report to the police, but we've actually seen in real life that there's a lot of firearm injuries that are not reported, even though we're required to. So kind of looking at those enforcement strategies and how we can sort of augment those. So in terms of, where to go from there, we were going to move on to, so those are some options you have in terms of what your denominators can be for your interventions that you're going to do. But I will have Patrick kind of turn it over and let him talk about some of the work he's doing and ways to get involved.
Thank you so much. Bye. Thank you.
All right.
I get a delivery service. I'm just kidding. Thank you.
Can people hear me without the microphone?
There's recording.
Okay. Sorry.
You do project.
So I'm going to talk a little bit about kind of a larger frame within what we can do in emergency medicine and emergency departments. I would argue there's a lot of different settings that we can do prevention research and violence prevention research and firearm violence prevention research. Healthcare is clearly one of those, one part of the puzzle. And emergency departments really are a key piece of that. We see a lot of patients that we send home. About 50% of patients with a firearm injury end up going home. So those patients aren't getting access to services that are available in the hospital. And so it really is key that we start these types of interventions that we do within the emergency setting. So when I talk about interventions, I talk about interventions at all different levels, and emergency medicine can be involved at all these different levels. So the individual level, the patient we see in front of us, the community level, and as well as the policy level. So I'll start by talking about some of the work we do, and then some of the other work that's going on in emergency medicine that some of our collaborators are doing, and kind of what role we can have in emergency medicine. So, So the first thing I talk about is kind of building on the surveillance work we already talked about. We can do surveillance within our own health systems. And so this is some work we did at one of our trauma centers in Flint, Michigan, where we looked at violent injuries that came into the emergency department and then looked at what subset of those were firearm violence injuries. And we looked at issues around who had a firearm and how they were acquired. And that can all inform the development of future interventions. We looked at 2-year longitudinal outcomes among that same population and looked at the rates of subsequent firearm violence among that population. And so a lot of this is work that we can do within our own emergency departments with funding from some of the sources that were already discussed. We can also look at firearm events uniquely. So this population of youth or adults that come into the emergency department, we can look at how they're using firearms, how firearms are being used in comparison with other types of violence events. This is a study we did where we looked at comparing firearm violence events to non-firearm violence events with urban youth who were involved in fighting and violence. And we were able to tease apart sort of what the underlying cause for the firearm events was in comparison to others, finding that 50% of the events that kids are involved in when they're involved in firearms are related to retaliation or retrieval of belongings that they think belong to them or somebody else thought they stole. Whereas what we see among non-firearm events is more underlying motives like jealousy or issues around girlfriends, boyfriends, that kind of thing. So we can start to tease apart where the interventions will be directed when we talk to these kids. We can also look at the role of alcohol and drug use and its association with firearm events. So the other role, in addition to surveillance, is prevention. And we can intervene at lots of different points in the prevention spectrum. So we can intervene. A lot of the work where I'm going to talk about that we've done is around primary prevention, so before the actual violent injury. We've also seen a lot of work being done in the area of secondary prevention, and Megan does a lot of work looking at tertiary prevention and preventing outcomes after being involved in violence. And why can we do this? Well, like I said, 50% of kids go home, so we're a key setting to intervene with folks. But also 50% of those youth who come in for violence were actually seen within the preceding 12 months in the ED for some other issue, whether it be a lower level violent injury or a medical reason. And so this population is coming in, they're being seen in our emergency departments, and it's an opportunity for us to intervene with them, and they won't necessarily interact with the system in other ways. So a lot of the work grew out of the NIH's State of the Science Conference on Youth Violence, initially that was held in 2004. And the kind of outcome of that was that EDs and primary care settings, especially within urban communities, are a key setting for violence prevention. And out of this grew a lot of work on hospital violence prevention programs. And there's a number of different ones out there. There's Youth Alive, which is out of Oakland. There's Healing Hurt People. There's Within Our Reach in Chicago. And a lot of these are built on this care management model of linking youth to available services within the community, substance use services, mental health services, job placement services. One of the problems with this line of research has been that there hasn't been the funding available to really investigate in a rigorous way whether or not these types of programs are efficacious. And we think they are, but we don't know. And so the evaluations have been mostly pre-post, not randomized control trials, and a lot of them had small sample sizes. And so because of that, we don't know a lot about what actually works and what doesn't work. But we have learned some valuable lessons from this. A number of the early programs were focused on kind of scare tactics, the scared straight kind of model, where they took kids through trauma bays or the morgue, and those have all been shown to be basically ineffective at changing behavior. What really is effective is enhancing protective factors and providing counseling around things like alcohol and drug use. And so a lot of the work we've done around youth violence in Flint, Michigan, has been really geared towards preventing early on in the spectrum violent behaviors and using counseling techniques to do that. And this is a rigorous randomized control trial that was done. It's called Safer Teens. It was done with a population of 14 to 18-year-olds who came into the emergency department and screened positive for alcohol use and fighting behaviors within the past 3 months. And those youth got a therapist-based motivational interviewing counseling session and were provided with some cognitive behavioral skills that they could use if they encounter situations with drug and alcohol use and fighting when they went back out into the community. And just a single 30-minute session delivered during their emergency care actually decreased their violence outcomes for out to a year. And also decreased their alcohol use and consequences. And we found in a subsequent analysis that it was cost effective. So some other work that's been done out of emergency departments by the folks in Seattle, and I know Doug Zaczek is one of Megan's mentors, has been looking at a similar type of model, a collaborative care model. Now, this study was done specifically around treating PTSD symptoms, but they found an ancillary impact of using collaborative care models at decreasing weapon carriage among kids who were treated in hospital trauma centers. So some of the work we're doing now is really taking that Safer Teens model and that collaborative care model that worked with a PTSD population and really trying to focus it specifically around firearms. And so this is a study we're doing right now in Flint, where we're taking kids who have higher level substance use and report having a firearm and doing, instead of that single session in the ED, starting with a single session in the ED and then continuing with remote therapy after they leave the emergency department. So a higher intensity intervention with kids who we know are at higher risk. And then we're supplementing it also with technology. We're putting an app on their phone that then allows us to send them messages to both help change behaviors as well as to then get data back that we can use to inform the therapy sessions that are delivered. So help to streamline the therapy and really be effective. So I'm going to shift gears. So I talked a lot there just about kind of youth violence and firearm violence among urban youth in particular. So I'm going to just shift gears for a minute and talk a little bit about suicide prevention and lethal means restriction. So Megan already talked a lot about how suicidal crises are short-lived, that means really do matter. So firearms have a case fatality rate of 90%, as we all know. So a lot of these patients don't end up showing up in our emergency departments. But if we can prevent them with access for the temporary period when they're in crisis, we can actually either prevent them from attempting to kill themselves, or they attempt to kill themselves with a far much less lethal method. And so the idea of providing lethal means counseling in an emergency setting is really kind of key. And so this is counseling to make firearms essentially inaccessible to at-risk youth. There was a prospective study that was done with emergency department children who got mental health, who were seeking mental health treatment in the emergency department. They found that those who got lethal means counseling were actually 4 times more likely to reduce, their parents were 4 times more likely to reduce access to lethal firearms and medications in the household. So we know that this can work. And there was an estimate as part of that article where if we did this even with low-level impact, so 25% of people actually responded to it, we could prevent 4,000 suicides among kids annually. The challenge that we have is that only 45% of ED physicians actually ask about whether or not there's a firearm in the home. So if we don't ask, we don't know, and we can't provide the counseling that's necessary. There's a lot of research gaps that remain in this area. What are the best methods for screening people for firearm ownership? What are the best methods for providing counseling? Amy Betts, that Amy talked about, is doing a lot of work in this area around what's the best way to intervene with this population. So there's ongoing studies looking at how we do effective lethal means counseling. Something else we can do, especially with a younger age population, is safe storage counseling. Again, if we don't ask, we won't know. But we do know from research that's been done in pediatrics that a high percentage of parents are receptive to being asked about firearms and receiving information about firearm risk during visits. And that anticipatory guidance around firearm safety can be effective at increasing safe storage practice. It has to be done the right way, so it has to be done with a more motivational interviewing framework rather than a more educational brochure approach. But those who received counseling were 2 times more likely to store their firearms safely. And another study looked at counseling, again with a motivational interviewing framework, found that 64% of adults who received counseling by their family physician actually changed their behaviors around storing firearms in their homes, and 12% actually got rid of the firearms altogether. So this can be effective, and if we ask about it, we can do something about it. So I talked a lot about things we can do sort of at the individual level with patients in our emergency department. But the EDA, as we all know, is also a link to our communities. And so we can have a much broader impact than just at the bedside with a single individual patient. And so this is some work we've done in Flint, Michigan. Again, we're more focused around youth violence and kind of urban violence. Sure. But this was an intervention we did where we took a large section of Flint, Michigan, and did an intervention among the neighborhood and had a comparison neighborhood where we did not do a series of interventions. Interventions were a total of 6, operating at different levels of the socio-ecological model. So we had individual level interventions, social interventions around mentoring, and community level interventions around community policing or clean green initiatives. We took patients who came into the ED from the intervention neighborhood, and we did the same Safer Teens intervention with them as part of this. So we were one of the 6 package of interventions. And we were able to, through this comprehensive sort of approach at preventing violence, decrease both ED visits for assault-related injuries, as well as police-reported assaults within the community. So this is some work that's been done, that's building off of that, and also builds off of work that Charlie Brandis and the Penn Group has done as part of their work. is really around doing vacant lot and community greening. And they found with taking urban blight and cleaning up the neighborhood area, they were able to decrease firearm assaults and violence within the community. There's a lot of reasons for this that are beyond the scope of being able to talk about in this short time frame, but we are extending this work now and taking it both to Flint as well as Youngstown and Camden to look at different methods of trying to do these interventions. And the ED can be a surveillance site for looking at outcomes. And I talked about, we looked at assault-related injuries that came into the emergency department in the prior iteration of the Youth Violence Prevention Center. We're doing the same thing with these types of interventions. We can be a surveillance site for interventions that are done in the community. So I'll talk just briefly about some of the work we can also do as emergency physicians at the kind of public policy level. And this is around looking at ways of preventing high-risk or dangerous people from getting firearms, developing technologically safer firearms. And so a lot of this work folks in California have been doing. Garen Wintmute has been very involved in looking at issues around background checks and waiting periods, and how we prevent illegal firearm diversion from legal channels to illegal channels, which we know is a big source of guns within urban communities. And so emergency physicians can be active at this public policy level, as we are in other areas of opiate policy and other policy-related issues across the spectrum. One of the other things we can do, and I know Steve Hargarten's here someplace in the back of the room, I think, is look around how we can make guns safer. So we can make improvements to guns around RFID technology, as well as loaded chamber indicators, higher pressure triggers. We've shown in research that kids as young as 4 can pull the trigger on a firearm, and if we increase just the pressure of how hard it is to pull the trigger, we can actually prevent a number of unintentional firearm injuries. So there's a lot of work we can do as emergency physicians within this area. And then I'll wrap up by talking just briefly about a new initiative that just got started out of Michigan, which is called the Firearm Safety Among Children and Teens Consortium. And this is an NICHD funded grant that's really around building capacity for physicians and public health researchers to do research on preventing firearm injuries among children. A number of people in the room are involved in it. Megan's involved in it. Steve Hargarten's involved in this research. It brings together leaders from around the country who are involved in firearm research. The aims of the project are fourfold. One is to develop a comprehensive research agenda for how we prevent firearm injuries among children, to conduct pilot research that will hopefully stimulate future R01s with NIH funding, to develop a set of research resources, an online data archive where we can house data around this issue, similar to the large data sets that were presented earlier, and then enhance existing data sets that are data that's collected through large networks like PCARN. And then the last aim is really to train the future generation of researchers in this issue. One of the big issues around firearm injury prevention is that there are only a handful of people who were around at the time that that funding was more robust in this area that have all that institutional knowledge to pass on. And so we really want to train the next generation before that generation retires, and we can be effective with that through this program, hopefully. And with that, I'll turn it over to Jeremy.
So among this group, I have the distinction of not actually being a firearm injury researcher. And rather than talking about some of the data, I'm actually going to walk you through a little bit of sort of my personal odyssey and explain how I ended up being up here on the panel. And it really comes down to my title slide, "Don't Say Stupid Stuff." So this was about a year ago. So I've known Lauren from a medical student through residency, and I had sort of lost track as she was working her way and developing her faculty research interests, what she was doing. And one day at shift change, I said, "What are you doing these days?" And she started describing what she's getting into with firearm injury and injury prevention and studying this problem. And I looked at her and said, you know, the problem with a lot of the literature out there is it's too easy for people that want to prevent gun control and other ways, regulatory-wise, of presumably decreasing firearm injury. It's too easy to pick a lot of the research apart because we tend to say stupid stuff. Don't say stupid stuff. Now, the other part of this is that I had already been on a little bit of a personal journey of my own, and I'd like to share that with you. But before we dive into my own journey, I wanted to quote Emmy Betts, who when I read this, I realized this was really what I was working for. This notion, we know that firearm injury, gun control, this is a highly politicized topic. There are very few people who don't have some kind of strong opinion about it that may or may not be based on any sort of reality on both sides of the discussion, and that there's a challenge we have of how you bridge this gap, okay? And just like other social issues that emergency medicine as a whole has taken on, this is actually a social understanding, okay? We don't understand the other people. How are we going to counsel them? Okay. And so when I read this, and we'd already started planning this session when I reread this, and it had some resonance. Let me tell you a little bit about how I ended up being up here. So I'm showing off a picture here from my high school yearbook. So that's 1991. I was a junior in high school. And that is the photograph of my public high school's rifle team. Maryland, just north of the Washington, D.C. border. I'm there in the back row. The guy, so, yellow hour here. Oops, sorry. And then the taller guy behind me was our rifle coach. He was a former Army sniper who his day job when he was not coaching the rifle team was he was a paid NRA spokesperson. Okay. Now, the other person in the room that the picture is a little bit dark is the young woman right here was my first girlfriend. Her pickup line is, I'll teach you how to play chess. If you teach me how to play chess, I will teach you how to shoot. She and her sister were near Olympic level shooters. And my parents were very excited about me actually having a girlfriend. And although they were and continue to be big supporters of gun control, they were willing to humor me on this one, okay? And then it turned out that I was really quite good at shooting. And they took the invitation, my coach came to the range, saw a practice, and then my parents, who were members and still are members of almost every gun control organization you can think of, bought me a rifle, which is that rifle that's down there on that bottom corner. I spent 2 years on the varsity rifle team becoming deeply engaged in the world of competitive shooting. And throughout that, I will also say my general worldview about firearms and firearm safety, other than enhancing my knowledge of how to be safe with firearms, I can't tell you that I suddenly thought that we should all have guns and carry them everywhere and all these other things that often is assumed to go with this sort of engagement in shooting sports. Although I was good at shooting, the college I went to had no shooting activities, and that rifle got stored away, disassembled safely, and locked up in a closet and traveled with me multiple moves until now, just a few years ago, here's me with my family, and my son joined Boy Scouts, and my daughter was there, 8 at the time, and we went to a Boy Scout event where the kids were learning how to shoot, and I was struck that the kids who had never handled firearms before, with proper instruction, handled firearms very safely. And guess what? The kids that clearly there were guns in the home were the ones that were making me nervous. And worse than the kids were the parents who were there, who weren't listening at all to the instructors. Okay? And I thought about that, and there was the issue that the instructors let in, gentlemen, we're here today to practice our Second Amendment rights. As it turns out, as much as we all may have some views about the NRA, in the NRA instructor instructions, that is not how you start out a lesson. You actually start out with, we are here today to learn the knowledge, skills, and attitudes necessary for the safe handling and firing of a firearm. Okay? So some of the politicization is not even what an organization like the NRA, when they finally take off their political hats and talk about something that had been one of their core values, is there. In the context of firearm safety and being at Grady at that point for 8 years and seeing countless gunshot wounds, when I came home from that trip and my 8-year-old daughter met me at the door and said, "Daddy, when are you going to teach me how to shoot?" My response was, as soon as I can figure out when and where to do it. Okay? And so this is actually an air gun that I purchased and then had to customize it to accommodate the dimensions of an 8-year-old. because my understanding in watching these scouts, kids who have had either no experience with guns or without guns, guns are a thing in our culture. Kids will have contact with guns. And in my view, the right answer is that we need to make sure that we are teaching about safety and addressing it. The problem that I had at this point is, although I had a background in guns and kind of knew the safety rules, is I didn't quite know where you go from there. And as I thought about it, as I discussed it with people, as I saw more people with gunshot wounds, I started developing a list of questions, a list of things that I felt me, our other faculty members, our residents, really needed to know more about. And you've heard about some of these issues in the educational and training programs. Things like safety and handling, different types of firearms and storage, these safety features. Some of them might actually enhance safety, some not so much. Questions like, how hard is it to actually purchase a firearm? How hard is it to get ammunition? We had a lot of things in our state about concealed carry, and it became a big thing. And when I went to find out what it was really about, what I learned was a little bit different than it had been portrayed. And the other thing that I noticed is that many of these topics don't necessarily really work well in a lecture format. These are things that a knowledgeable person at the bedside with a patient with the injury describing what happened might be the teachable moment. And some of these things you need to go someplace, I believe, and probably there are some of you who will disagree, but I believe that the best way to teach some of these issues is to go someplace with appropriate supervision and actually see a firearm, perhaps handle. I don't feel like anybody has to shoot, but in the number of people I've worked with that I've said, why don't we go to a range so you understand this? I've not encountered anybody who didn't like guns who walked away from the range suddenly liking guns. Okay? I have had some people who thought they liked guns and walked away from the range going, yeah, maybe this is not for me. So that whole argument, oh, go to a range, maybe it will convince somebody, I don't believe that that's really a thing, particularly if the emphasis is about this knowledge, skills, and attitude, and understanding the problems that we're seeing in our community. So my version of things, I much prefer to do things, if you hadn't guessed, and that seems to be an ER theme. This is very much a learning by doing experience. So I was caring for lots of people with gunshot wounds, and I started spending more time asking them about how their injuries happen. And the good news from those years on the rifle team and all of that, I kind of knew what they were talking about. I actually took just a gun class. It's been 20 years since I've really shot. Maybe I should see what else I can learn. And I realized that that wasn't really going to get me to where I wanted to be. So I dusted off that rifle and I qualified for an instructor class. Right? If we want to have credibility as being the people that own this topic, I am an NRA certified rifle instructor. Okay? I did not join the NRA to do that. In case anybody's worried. You don't have to, but this is something where there are a lot of ways to get to the point where you can be knowledgeable as the people who are on the other side of the debate. And again, I'm making assumptions that many of you are going to be more on the side of more gun control, fewer guns. But this is something that you can do. And if you go back to Emmy Betts' her editorial in 2015, there is a need for a group of us, not everybody, within the emergency medicine community, within the firearm research community, who have this deeper level of understanding to make sure we don't say stupid stuff in papers, to make sure that we are appropriately educating our residents and our other trainees about this, that we're having good conversations about how to have the conversations with patients. I kept on going. I took the instructor class. I got a concealed carry permit, which in my state cost me $83.76, fingerprinting, and no education whatsoever. You go like getting a marriage license, and the lady is just as cheery when you hand in your form. Now that being said, I purchased a firearm. In my state with a concealed carry permit, I can be in and out of a gun shop in under 5 minutes with a firearm and ammunition. Okay? That's not quite what you're led to believe in our state about how restrictive gun laws are and how onerous it is to get a gun. but I have done it and I didn't do anything. In fact, I was shocked. I went in, they said, can I have your concealed carry permit, your driver's license, fill out this form, I did. And they're like, this was the one you wanted. We ran your credit card, here you go. Do you want ammo? Extra magazines? Right? These are things that outside of the political debate, there is a reality of how these things work that is a little bit different than what you may believe, what you've been led to believe, what people would like you to believe. And some of this, I'm not saying that everybody who does firearm injury research or is interested in this area needs to go buy a gun or even have fired a gun, but a few of us need to be doing that to make sure that everybody else is working with a full set of knowledge. Probably the most important thing that I've been doing, and part of this is the training process, is spending a lot of times with firearm owners. And guess what? Firearm owners are nice people, by and large. They're normal people. They are your neighbors. Just when you start talking about taking away their guns, things get a little weird. But they're nice people. Many of them are very, very knowledgeable. Many of them are happy to share their knowledge. And then working from that position, increasing, as my residents can attest, I am sharing what I've learned. And I think that this creates a little bit of an opportunity of how do we set up resident educations, faculty education on this topic. So if we're doing political advocacy, we can say things that are not stupid. If it is a matter of research, we can say things that are not immediately undercut by a small technical error that really has nothing to do with what the science is actually telling us about the situation. So questions that we've sort of been discussing and how to more formally do this is, how can we help our colleagues, our residents, our trainees understand patients' feelings on this topic? How can we bridge this cultural gap? I believe this is a challenge that's similar towards training trainees to talk about sexual behaviors, right? We have taboos, and they're just much more political rather than privacy and religious and other things in this topic area. And that gives us some rounds to advancing the research agenda, which I think everybody else has covered much better than I could. And also start looking for areas where there is, in fact, common ground on those of us who would like to see fewer firearm injuries and the firearm enthusiasts. There's another slide which I'm going to skip, and if there's a good question, I'll use it. But does anybody in the room know what in the firearm community, when a firearm unintentionally discharges, what they call that? What was that?
Misfire.
Okay, so misfire is a specific thing when the action of the gun goes off and the gun either doesn't fire or fires improperly. So the terminology that's widely being used is something called a negligent discharge. Right? Does that terminology negligent come as a surprise to you? To me, that speaks volumes that there is some common ground that within the firearms community there's actually interest in preventing firearm injury. And I think that having a few of us who are literate in this area, actually there may be a lot more avenues for finding that common ground. And as unlikely as it seems politically, finding ways that we can work together.
Thank you, Jeremy. All right, so I guess with that, here, let me get to our last slide. We wanted to open it up for questions and have our contact information for anyone that's interested in some of the topics that we discussed today. Does anyone have any questions? We covered, ideally we would have loved to have done a long workshop with drawn out parts on each one of these, but given it's a 50-minute session, we had to give you the Cliff Notes version. But does anyone have any questions?
So if there are no questions, I actually think that Jeremy's talk is a really important point, I think, for all of us. And when I give kind of an hour, I know that Pat and I both, when we give like an hour-gram rounds about this, I think it's really important for all of us to be careful or thoughtful in our language. That to me, this really is about harm reduction in whatever population it is that we're talking about. I know I've had very heated discussions with colleagues on both sides of the political spectrum, nurses, fellow physicians, administrators. And there is this wide perception that when we talk about firearm injury prevention, that somehow that is a code word for gun control. And I want to be really explicitly clear that that is not what this is about. There are likely policy changes, and we have a small amount of evidence that some policy changes do make a difference in terms of reducing access to those at risk and in terms of keeping people safe who can't keep themselves safe. And some examples of some of those are the extreme risk protection orders, which have been put in place in California and Vermont and are currently being looked at in other states to prevent things like Parkland, where everyone knew that the guy was at risk and that he should not have had access to guns at that moment in his life, right? But there are many other things that don't have evidence behind them yet, if at all, if they ever will. And there are a lot of things that we can do that don't require policy change. In fact, most or many of the interventions that are needed likely don't have anything to do with policy. They may have to do with enforcement of existing laws that are already on the books. They may have to do with consolidation of laws. But they may also be stuff like a lot of stuff like what Pat talked about, whether it's lethal means counseling or violence intervention programs, where it's about providing resources and community support. But the really critical thing is that we have to be able to talk about it, right? We have to be able to talk about guns as a mechanism of injury, just as cars or pools or prescription drugs are a mechanism of injury, right? We have not taken cars off the road, and yet we have decreased the rate of car crashes. We have not stopped people from having sex, although some people may have tried, and yet we've decreased the rate of HIV/AIDS, right? Abstinence does not work. And I don't think that it's a legitimate conversation. I think that each of us can make our own choices. We can have discussions around kind of cultural preferences. But I think it's really important for us to recognize, and again, where you live, it's going to be a slightly different conversation. There's going to be different perspectives in different states. But when we need to be thoughtful about how we talk about it in a way that doesn't make people afraid that we're going to be going house to house and taking guns, which is a fear that I hear, right? And that's not what this discussion is about.
I would just echo that and say one of the things that was key to the new facts initiative that I talked about is we are engaging a broad stakeholder group of people who are gun owners. And to answer questions around things like what's the best messaging for safe storage counseling for gun owning parents, right? We don't know that. And the only way we can get that kind of information is to work with people who own guns and have guns and store guns in their household.
And maybe some of them will decide to not have the guns in their household, right? Like we know that having a gun in your household, if you're suicidal, even if you have it locked up, one of the stories that I tell when I start my talks is a story of a kid who killed himself with his father's own gun. The dad's gun was locked up, but the kid knew where the key was, right? And so for some groups, there's gonna be a time period where maybe getting that gun out of the house may be a better idea. But we have to recognize that just as we tell people, you know, and I'm not saying that there's an equivalence here, but we talked about kind of harm reduction for shooting up, right? And many of us accept that as being something that we should be doing. Similarly, let's talk about harm reduction, recognizing that we are a really diverse country with really diverse reasons for doing what we do. And that we should not be prescriptive, but rather we should make it easy for people to avoid being fearful, right? Which is the reason for a lot of this, and to keep all of us safe.
So the most common thing is describing the item that you put the cartridges in to quickly load a firearm as a clip, as opposed to a magazine. And it's the most idiotic thing, because if you go to a gun range, you'll hear all sorts of gun enthusiasts say, "Yeah, hand me a clip." But a clip is technically a particular, essentially a strip of metal or circle of metal that holds on to the cartridges. Another one, and again it's stupid, you notice I said cartridges and not bullets. The bullet is the projectile, the piece that you put in the firearm that contains the powder, the propellant, as well as the projectile, is a round, a cartridge. The bullet is only that piece on the end that goes flying out. And so it's something where there's a lot of these very small things. The example, one of the things that I guess more on the clinical side of things, we have a patient who shoots themselves, all right? If you shoot yourself unintentionally with your own firearm, if we go to the NRA's website about your firearm safety rules, you violated 3 safety rules, all 3 of them. right? And we know if we approach a firearm owner who just unintentionally shot themselves and say, dude, you shot yourself, maybe you shouldn't have a gun, I don't think that's going to go very well. But if you approach it from, let's talk about what happened here, let's think through what are the safety rules that are part of what is recognized as being part of responsible and safe gun ownership. Always point your firearm in a safe direction. Well, it was pointed at your leg, so no, not that one. Always keep your firearm unloaded until ready to fire. No, not that one. Okay, and this one goes to the issue of being knowledgeable about firearms, but keep your finger off the trigger until on target and ready to fire. And the reason why this is a knowledge one, the most commonly owned firearm handgun in the United States is a Glock. The way you disassemble a Glock for cleaning requires that you pull the trigger. Okay? So this is one of those things, a tiny little bit of knowledge, and you think about it, almost all of us have seen the gunshot wound to the left leg. Why does that happen? I've got my gun. Here, hold the mic, please. I got my gun, and I'm working the slide to try to start disassembling, and I pulled the trigger without making sure that there was no magazine, no round in the chamber, pointed down like this, right-handed, left leg. There it is. And it's amazing when you talk to a firearm owner who has just made this error, and you go, so, left leg, was it a Glock? It is amazing because there's like almost a bonding moment. They're like, oh, you know something about guns. And again, the depth of knowledge is know that Glocks, as well as some other guns, require that you pull the trigger. Know those 3 leading golden rules of firearm safety. And you're at a starting point to have an intelligent conversation as opposed to, if you were dumb enough to shoot yourself, probably you shouldn't have a gun.
It's just like what we do for alcohol, right? We get taught espert. It's not telling someone, don't go drink, you're going to go kill yourself, right? Like we learn the steps about getting them to a point where they drink less. But I will say that kind of even with your comment, I think it's still worth having a conversation in a respectful way. Yes. I don't know everything there is to know about shooting up. I hope I never, it's not something, but I'll still have conversations with my patients, right?
I thought maybe you might going to say something about gun versus firearms. I see you are very careful about saying firearms except for a handgun. And a lot of times say gun safety or, guns.
Yeah, so the terminology there is sometimes one of those nitpick points. Doing a firearm instruction course has been fascinating. I will say there's relatively little politics in the instruction. One of the very shrewd but clearly very political things in an NRA firearm instructor course, you never refer to the firearm as a weapon. Okay, which for those of us, my original training in shooting was with a military instructor. And military and law enforcement instructors, a firearm is one thing and one thing only. It is a weapon. Okay, and again, think through why the NRA would not want to characterize that way. But the tradition in instructor courses is anytime anyone refers to the firearms, the guns, the rifles, the handguns as a weapon, dollar goes into the jar. It's like the curse jar. And it gets to be a running joke if you're in a class with people from law enforcement and military. My rifle instructor course, we said rifle a lot, starting to say weapon, but then switch it over to rifle. So the terminology, and again, it's a subtle point, but the argument would be it's not a weapon until somebody has the intention of using it to cause harm. It's splitting hairs, and unfortunately the political debate often breaks down into a lot of splitting hairs and not a whole lot of substance.
I think
yeah, there's 2 more I saw. Yeah. Do you want to go ahead?
Oh yeah, just following up on that point, I know Megan showed the data that only 1% of fatal injuries are unintentional, and when we looked at national data for ER visits, it's almost 50% are these unintentional injuries. And so I guess the question is, when we have the guy who shoots himself in the leg, are there best practices for counseling in the ED to prevent sort of secondary injury?
Not in
Great
the,
question.
great question. Not in the ED setting yet. I mean, there's been some stuff done in the primary care setting around firearm safety and safe storage and safe handling, but nothing in the ED yet. So it's a ripe area for work.
And there was just a meta-analysis or systematic review that just came out looking at gun safety training programs and whether or not they actually improve safe practices. And the data that's out there shows that, at least from what's been studied, they don't. May good training programs make a difference? Possibly. We don't know. I mean, of course, we haven't had funding to do this for 2 decades. So.
Yeah, and that data around children has been pretty clear for years. So teaching kids gun safety through the NRA's course and some of these other courses that are out there doesn't work. They teach them slogans around how to not interact with a gun and go find an adult, and the kids remember the slogan, but they go and they play with the guns. And anybody who's had a kid knows that.
Yeah, and going on with that, I did not send my kids to an NRA safety training course. I took my children someplace where I could teach them real
Theater.
adult firearm safety, okay? And I got them someplace where I could set my daughter and my son both up and actually pull the trigger and have a discussion about what that's all about and about how I'm letting you do this here so you never do this under other circumstances. Yeah, I think parts of the NRA training thing are good in terms of teaching safe practice. Whether they work or not, it wouldn't surprise me that there's not much data on it. It's the right messaging. I have a lot of concerns about the programs targeted at kids.
I would just emphasize that I think the right message is safe storage, right? So it's not around, I mean, you can teach kids around firearm safety, but when we're dealing with our patient population, the message to the parents is around safe storage because when they're not there, kids will find the gun and they'll play with it. And the number one unintentional injury that we see is siblings shooting siblings. So
I think I saw one more question, and I promise we'll be done. I can tell. Okay, go ahead.
So I work at an institution with a new trauma center, and we have a group of trauma faculty that are really motivated and have a pretty great vision for sort of strong incorporation of violence recovery in the trauma center. But what I haven't been intimately involved with it, but what they run into is just sort of a lack of funding for the actual violence recovery work. And so you talked a little bit about the research. I'm wondering, in your experience, are there other sort of avenues that we might
Great question.
consider for
So one of the best things, there's a national network of hospital violence intervention programs, and for those of you that are on Twitter, I did kind of include them in one of my tweets out about this, which is what I was doing under the table, by the way, not emailing. So NNHVIP is a great resource. They have standard protocols for hospital-based violence intervention programs, for best practices. They serve as mentorship. Funding is really, really tough, right? And so the HVIP programs that have been most successful usually get either county or state or hospital resources to get put into them. Rochelle Dicker, who was at UCSF and is now at UCLA, has been tremendously successful. There's a program at Highland that's been great. But most of the programs that are out there that are continuous get some sort of governmental funding. There is some foundation funding, but it's waxes and wanes, right? And so the other option is to find a big donor. And you're in Chicago, am I right? Yeah. So I would imagine, so Joyce Foundation might be someone to approach. They generally don't fund medical stuff, but they may at least be willing to put you in touch with the right people. The other thing is that if it's something to go to donors from the hospital and to say this is a community investment, this is a great way for us to give back. Here you've made this huge resource into making us a trauma center. Let's do the right thing for our community. This can count as part of your community-based payments, which every hospital is supposed to be doing. They have to itemize what they spend on community resources each year, and so to try to go about it that way. But NNHVIP is a great group for camaraderie. I don't know if any of you have.
No, and they just started one at Grady recently, and tying, like we talked about, in with criminal justice and policing, like safe community policing. They recently have gotten funding to start a hospital-based violence intervention program in conjunction with a community policing program, and that's kind of how they sort of backdoored that. And so I think that's another. So if there's any relationship build you guys can do with to try to improve relations with policing and community efforts, they can. A lot of these hospital-based intervention programs firearms have community ties or community element, just like Patrick had mentioned, that nested sort of model. So if you can sort of do it that way, then you can get funding. Yeah, get funding.
And I'll just mention the long-term sort of strategy and vision for this is we're doing an implementation study right now where we're measuring cost, and if we can show that it's cost effective essentially to have folks who can do these interventions from the emergency department setting, then we can get reimbursement for them. So we have a Medicaid match project going on right now in Michigan at Hurley, where we took the Safer Teens intervention and we're implementing it within the clinical setting with social workers in the department delivering the intervention. And the vision for that is if we can show that it's cost effective, then we can get reimbursement similar to alcohol brief interventions.
And that's actually, that was, so Kyle Fisher, who's an emergency physician at Maryland and is part of NNHVIP, has done advocacy for years on the national level and has now got it so that peer violence counselors actually can get an NPI number, and is working on creating a Medicare code, which then also facilitates the reimbursement portion. So Kyle is a great, I know he's not here today, but he is a great person to reach out to. Is very active within NNHVIP, but also has just a ton of knowledge about kind of if that hospital billing is something that you want, if you enough of your folks are insured, have gone through, I don't know if Chicago, if you guys are a Medicaid expansion state, you are, so probably a large, if you're like my trauma center, we went from like 40% uninsured to now 40% Medicaid, right? And like, so in that context, it makes sense to look into the reimbursement. So Kyle's a good person.
All right, well, with that, guys, we are already well over, so we'll break, and if you have any questions, a couple of us will hang around. I know Meg's busy, so she probably got to run, but if you guys want to come up and ask questions, we'll be here. But thank you again so much for coming.
Thank you, guys.